that has been really a team effort, and you know, it was my colleague Dr. Jeremy Chang who has been leading you know, all the development on vitrification. So it is just a wonderful team, and you know, you are part of that great team. So thank you so much. You know, I also appreciate for I3 giving me the opportunity to talk about PGTA and also what is the effect, as well as the concordance after rebiopsy. So we all know that the goal of IVF is to provide infertile patients with a healthy baby. And obviously there are other points to consider, like how much time does it take, you know, to get the baby, how much does it cost, what is the convenience, whether, you know, the patient has to try one time the IVF or 2, 3, 4 times to get through an IVF stimulation cycle. It's also important, you know, if the couple is desiring to have just one child, or if they would like to have 2, 3 or more children. So depending on all this, what patient wants, approaches may differ. And you know, we all know that embryo assessment, what we practice in the IVF since the beginning of IVF, is helping to improve efficiency of the IVF process. Now, the way that we do the embryo assessing is to try to identify those that are viable and contribute to a healthy single-atom pregnancy after a fresh or frozen embryo transfer. We do that, you know, traditional method with the microscopy examination of the embryos. However, this approach, as we all know, it's not very efficient, not very reliable, and that is the reason that, you know, our community is looking for additional tools for quite some time. And you know, one of the best known and applied tool already for decades also, what we call the PGTA, or how is it called earlier, PGS. This tool is looking at the chromosome composition of a biopsy sample and able to identify viable or non-viable embryos based on that test. So let's just give an example here. A patient who has 4 high-quality embryos, morphologically they all look very similar, and let's assume that if this patient has a 50% implantation rate with these 4 embryos, this means that if you transfer all 4 embryos, then at the end the patient will have 2 babies out of these 4 embryos. Let's also assume that the aneuploidy rate for this specific patient is 50%, which is quite usual to see a 50% average aneuploidy rate. If that is the situation, and you perform an embryo biopsy, and you deselect those embryos that were aneuploid, so you have 2 euploid and 2 aneuploid embryos, you remove the aneuploid embryos, and now you are using only the euploid embryos, and you transfer only those 2, then you should also have the same 2 babies out of it. And that means also that your implantation rate now should be increased from 50% to 100%. And that's where the efficiency of PGTA is coming, that you are creating a selection, and the selection by removing the non-euploid embryos, and then you don't waste time and money for those transfers. However, the question is what the data show. And you know, I looked up the SART data from 2018, and that's you know, maybe not the best approach because it's a little bit of mix of bags of everything, and you know, not perfect. It's not a real study. However, it's also showing, reflecting, you know, the daily reality, what we are living in. And those that are not living in the United States, you know, SART is an organization that is collecting data from all or most IVF centers in the USA, that there are somewhat more than 400 IVF centers. And from 2018, what it shows that for patients who are younger than 35, the implantation rate was 46%. Those that had no PGTA, no biopsy. Now, in the same patient population, if they had a PGTA, then the implantation rate improved to 53%. For the patient age group 35 to 37, implantation rate was 41% without PGTA, and it increased to 55% after PGTA. Here at RBA, we looked at the same data, and we have seen that, in the youngest age group, less than 35, we had 53% implantation rate without embryo biopsy PGTA. That increased to 62% after biopsy and PGTA. Now, we can see that, yes, there is some improvement after biopsy and PGTA, but I think most of us would question, is this, sufficient improvement? Is this what we expect? And I think most of us would think that no, if you have, let's say, 40% aneuploidy rate in the group of 35, and let's assume that you have 30, in the less than 35, you have 40% aneuploidy rate, and you remove that 40% of embryos from the group of embryos that you transfer, then I actually calculated what should be the expected implantation rate in this group, and that should be 76% and not 53%. And similarly, in the 35 to 37 group, it should be 82% the expected implantation rate and not 55%. So, and we got similar results also when we looked at our RBA data. So, looking at, SART result is not the perfect way. Doing studies is a better way, to see what is going on really. And I just want to refer to one slide here from a study that was a multinational, multi-center randomized controlled trial, pretty well designed, not perfect, but pretty well designed, where they transferred just a single embryo either after PGTA or without PGTA, without biopsy. And that's a very recent study actually. And what you can see here in the patient age group of 25 to 34, the pregnancy rate, again, single embryo transfer, was 53%. And after PGTA, it was 49%. So actually, instead of improving the pregnancy rate, it seemed like a little bit of decrease. Of course, that statistically was not significant. In the patient age group of 35 to 40, they saw 37% pregnancy rate, ongoing pregnancy rate in the group of no PGTA, and 51% in the PGTA group. So here we can see a slight increase, although it didn't really reach significance that either. Now, this study data was used by another group who published their findings that they tried to establish that, what was the result of that study on the patients. And they have published this in Reproductive Biomedicine Online only just a couple of weeks ago, saying that if you did PGTA in this patient population in the STAR study, that led a reduction from 82 to 50% of the cumulative live birth rate for competent embryos. And, to go back to our example where the patient had 4 embryos and we got 2 babies out of it. Now, if you are deselecting the 2 aneuploid, then based on this study result as well as, the SART analysis, basically that means that instead of getting 2 babies after PGTA, you probably would get just 1 baby. So the question comes up, what is the cause of this discrepancy? Some would ask, okay, is it a technique-related NGS? And, I'm not expert. I'm embryologist, so I'm not expert on NGS. But if you talk with experts, Gary and others, they will say that this is a rock-solid technology, and I believe them. I think that's the great technology. So what else can it be? It can be, of course, embryo-related and also IVF lab-related to see that, what we are doing as embryologists in the IVF lab. And, we know that culture conditions can determine not only how embryos are developing, but it seems that it also determines that, what is the proportion of embryos that have chromosome alterations, depending on those culture conditions. And of course, also some of the procedures that we do in the lab, like biopsy or tubing, that can also determine. And actually, that was the main focus of this webinar. And those 2 points will be discussed in the next 2 presentations, which is, I think, extremely important that we try to have more understanding and try to do our best. I just wanted to refer here a little bit to remind us, what are the origins of chromosome abnormalities in the embryo. And there are two origins. One is what we call meiotic errors, which means that there is a chromosome abnormality either in the sperm or in the oocyte or in both. And when that happens, then the resulting embryo, in every cell of that embryo, you will find the exact same chromosome abnormality. So that's a uniform abnormality. During mitotic errors, and actually that happens quite frequent, which is a post-zygotic error, if there is a chromosomal abnormality arising, then typically that will be confined just for some of the cells, and it's not going to be present in all the cells. And here I just also wanted to remind everyone, and there is no time to discuss about it more in detail, about cell cycle and cell cycle checkpoints. Because what happens when the cell is dividing and goes through meiosis or goes through mitosis, there are cell cycle checkpoints. That means that when the DNA is duplicating and the chromosomes are matching up on each other, if there is any mistake, then those checkpoints, they say, hops, that's not good, and stops the cell cycle progression. So in theory, if you have a chromosome error in a cell, then it's not going to be able to divide. So unfortunately in human, that's not working very efficiently, and that's one of the reasons that a very high proportion of embryos have chromosomal abnormalities. However, sometimes it does work and stops the cell cycle and stops the cell dividing, and that's when you sometimes see, after collapsing a blastocyst, some larger cells in the peridigital place. So here I wanted to jump to the second topic that is related to, of course, to the topics that I have been discussing here, which is concordance after rebiopsy. And what we did here at RBA is that patients who had embryo biopsy PGT testing and it came back as abnormal, 1 or 2 chromosomes abnormality, either full abnormality or mosaic and segmental, and the patients donated those embryos to research. Then we did total embryos, and depending how many cells the embryo still had, we took out some other pieces and then we analyzed those pieces. We tested a total of 79 embryos and a total of 213 samples. And basically what it showed, that 85%, 86% of the time, it showed a complete match of the rebiopsy sample to the original diagnosis, to the original testing. In about 13%, it showed a partial match, and in 2.6%, it showed a complete mismatch. Now, in this table, we did not include the mosaic or the segmental testing diagnosis, but when we included those also, the mosaics and segmental, then the complete match actually decreased to 65%. And there are a few publication studies about the same concordance question after rebiopsy. One is from Chang and Korix from Molecular Human Reproduction from 2018, where they looked at the 2 trophectoderm biopsy matching that was 90%, then the TE1 versus the ICM that was 86% match, and the TE2 with the ICM that was 90%. So their finding is somewhat similar to ours. Saktev and colleagues published in JARG this year, where they found that about on 32 embryos that 40% of the rebiopsy specimens were concordant for all chromosomes in the initial biopsies, and they found that it was higher, the concordance, when the embryo was euploid or aneuploid, but it was lower when it was mosaic. So in summary, we can say that PGTA may improve implantation rate per transfer, but it does appear to decrease cumulative pregnancy rates. Rebiopsy retesting of embryos show that there is not a full concordance with the original test results, especially in mosaic cases, and that the role of IVF laboratory to optimize outcomes after PGTA is really important. And the critical elements include embryo culture conditions, embryo biopsy and tubing techniques, and cryopreservation vitrification. That's a topic that we didn't really talk about. I didn't talk about it. There is no time on one hand. But it's extremely important because most of the time when we do biopsy and PGT testing, that embryo is going to be vitrified and used in a frozen embryo transfer cycle. So how we perform, cryopreservation vitrification is actually very impactful on the outcomes and results. But thank you very much.